Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMFS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, welcome to their episode. Appreciate everyone tuning in and listening. Today I'm with Dr. He's an oral and maxillofacial surgeon practicing in the Atlanta, Georgia area. Shahrokh, thank you so much for joining us on the podcast again.
Thank you, Grant. It's a pleasure to be back on. It's, I believe, been about a year since we spoke last time.
Yes. Yeah, I had a bunch of great feedback from the episode that we did last time. Several, residents and younger surgeons really appreciated your perspective on the current landscape of oral surgery from a private practice standpoint. We want to maybe do kind of like a part 2 on that discussion. You are in private practice in Atlanta and you have a fellowship there. Anything else you wanted to mention about your practice?
Well, everyone's unique in their own way, but I wanted to say, first of all, thank you for having me back on, and thank you for the kind comments from the audience. What you have to recognize, Grant, is that you've been this outlet now for, a few years, if I'm correct. And you must have yourself acquired a wealth of knowledge because you're listening to all perspectives from different characters, if you will, from oral maxillofacial surgery. And you have to give yourself a little bit of credit here. Perhaps you should podcast yourself because you've gained a vast knowledge from different vantage points of all these colleagues and friends, and some people even outside of our profession. So maybe we should reverse you one day and I'll podcast you and see what you've gathered from all these years. And perhaps the residents will call and ask for you to speak. I think they probably will, and I would be tuning in. But with that, so thank you for doing this. You are become an icon. I believe your listening crowd has increased, if I'm correct, and you can share those statistics if you wish. But anyway, yes, we are here in Atlanta. Atlanta is a growing town. It's a growing metropolis with, I think, the metro statistical area is over 6 million. And that our practice is much of the same as last year. We do have a fellowship track. It's a fellowship in craniomaxillofacial trauma combined with cosmetic surgery. We cover level 2 trauma center, and much of the same basic oral OMFS and some of the reconstructive surgery that goes along with it. So we're still enjoying doing that with the challenges that goes with it. So I will just say one thing, and then maybe you can pick up on this. The one good news, and in the years since we've talked, I don't think a whole lot has happened, but there's a few things that have popped up. But number one is, this is no news, is that the demand for our services remains very high. So oral and maxillofacial surgeons are in very high demand. Yes, there is areas in the country that there's more competition than others and more saturated in the more desirable locations, but we are a desirable specialty, and we can expand on that because different parts of our specialty are more desirable to the public, or there's more need for it, if you will. That's a better word. Others. So that's the good news. What has been your impression of that, Grant?
I mean, yeah, in my area in Denver, it's the same. I think super high demand, still lots of work. So not, like we've talked about before, I think we're blessed in our profession, and that I think it starts honestly with how hard it is to open oral maxillofacial surgery residents. And there's just not a ton, residents come out every year. And so that's kind of like good for our profession, at least for those practicing, is there's not a surplus of providers. And so there's still a lot of work. A lot of people need our services. It's very valuable. A lot of people in pain, a lot of people with infections, necessary surgeries that need to happen. And so, yeah, same here. No shortage of work for me.
That's great. The challenges remain in organizing our delivery of services in a way that is well distributed and well compensated, well deserved, and sort of brings that job satisfaction to folks that have trained for so long. I think that the couple of things that are new in our profession since, I guess, a year ago. One is really there's been a big surge of AI stuff,
Yeah.
softwares, auxiliary softwares that can help, and that has popped in, I think, really in the last year for the most part. And that's going to change. Clearly, it's going to change medicine, surgery, and dentistry. There's going to be factors that, by and large, I think will help from what it seems like it. If the quality of the material is good and it doesn't put the liability on our shoulders in a different way. I'm using some AI tools. We are still responsible ultimately ourselves of what we do. So I think that's a big deal. It's going to be on the diagnostic side. So AI
Yeah.
makes diagnosis, subsequently recommendations, and that's why it hasn't hit in as hard yet, but I think it will in fields like radiology. That's very a big debate and things that are happening. And then in the sort of efficiency side of practice with helping notes and documentation and those kind of things are certainly on the horizon. I think if we were to have this podcast in 5 years, maybe sooner, we would be noting vast differences in how practices are done. And it's happening so fast that the generation that's coming in will adapt to it and forget how it was prior. The interesting thing is that when we talk about generations in real life, a generation is sort of when you have a child and your next generation is the next generation. But in oral maxillofacial surgery, the generational time is perhaps 4 to 6 years, because that's when new residents come. So when we talk about next generation, it's not necessarily your children's level of people. It's like 5 to 10 years later, and things change very fast. And
Yeah.
I've been in practice 25 years, and I think I've gone through like 5 generations of how things have turned out and changed about. Are you seeing some AI stuff? Have you had some discussions of that in your podcast or in your personal practice?
Yeah, we've had a discussion, like you're saying, on from the diagnostic standpoint, especially, probably seeing AI's ability soon here to go through x-rays, enhance things for you, make suggestions about diagnosis. We don't have that built into our Epic software yet, but I think that's coming. I mean, I also think on the medicine side, like probably, in the next couple of years, you'll see AI be able to go through their EMR, read everything about the patient, and then and maybe read your note even and say, okay, given what you're saying the patient has going on, here are medications you could prescribe them. Here's whatever potential, treatments you could offer them. So that will be interesting to have, that AI, I guess, opinion or suggestion going on there that I'm sure will only evolve and grow over time. It'll be very interesting to see how that changes.
It will evolve, and perhaps not all of it is positive, because one of the things that I think surgery is as a profession is also a very intellectual profession. So it requires us that we think and we solve puzzles, and I do have a comment on that perhaps later. But AI, the better it gets, the less the surgeon has to think, essentially, to figure out, and becomes more of a task. So the thinking starts drifting away, and the task-driven part perhaps increases, so that it says, well, you have, based on this CT scan, you have a zygomatical maxillary complex fracture, and it's displaced, 7 millimeters, and you would have to do the surgery. And you're like, oh, okay, thank you, Mr. AI, I'm going to go do the surgery. But it put it in perspective. I think it could probably be more helpful than otherwise, but that would emphasize that their educational programs should continue teaching the academic side. And I can't tell you, the more the residents and colleagues that I've interacted with in the last couple of years, vast majority of them perhaps are interested in, let's do surgery, let's do operations, I want to do surgery. And that's important, of course. And I would ask, well, what do you know about the history of our profession, or how did, for example, rhinoplasty work its way into oral and maxillofacial surgery? And people usually have no idea about that. I think that historical perspective is very important, and that we maintain. So in one of the suggestions I have to colleagues that are young in the profession or are graduating from some of our programs is that when we get excited about doing any aspect of our profession, like orthodontic surgery or trauma or cosmetics, I highly encourage folks to go back and learn the historical perspective of it. For example, orthodontic surgery, which is one of the sort of founding complex procedures of our practice that we sort of strived at, has a rich history that goes back and forth with Europe and in the United States. Hugo Obergeiser, which of course came and gave that famous lecture at Walter Reed that triggered the American oral maxillofacial surgeons to pick up orthodontic surgery skills, and this goes on and on. It's very important. So if you're going to learn orthodontic surgery, you need to know these things. If you're going to learn cosmetic surgery or rhinoplasty, for example, you can't just learn how to open a nose and move the cartilages and the bone. You have to go back and find out how some of these things and who were the players and how from plastic surgery to facial plastic surgery to fellowship trainings in oral maxillofacial surgery, these things creeped into our profession through research and through academic teachings and from folks outside our specialty going into other specialties and learning it and things like that. And those are very interesting, and it's very important to know these things, in my opinion.
Yeah, for sure.
The triad, if you will, of being a good surgeon, and this is purely my opinion, it's sort of a three thing. You have to know how to do surgery and medicine, which is what the residency and schooling is about. So we learn some of that, and we can get sidetracked by that. But the operative part, of course, is what I'm talking about. The second is the intellectual part of surgery. There is an intellectual part that can sometimes be overshadowed by the excitement of doing surgery. And which is the historical perspectives of it, the science behind why bone grafting or certain types of new material or physiological acceptance of things in the body. Those are very important for folks to know, the physiology, anesthesia, and so forth. The academic intellectual part of it has a lot of history, how that became into our profession. And lastly is the third triad is our personality and our outlook, if you will, our bedside manners and how we present ourselves to our profession or to our patients. If you can master those three things, I think generally people are going to have a successful outcome no matter what venue of practice you go into, private or academics or new setup or whatnot. But
yeah, I agree. That's a good point to bring up, because sometimes we focus, on one or more of those things and neglect one of the triad. I'm thinking specifically, I know surgeons, of course, I feel like most of surgeons are very intellectual, very smart. Just to get where we're at, you have to be, pretty smart guy. A lot and most probably are good with their hands and surgically, but not all. But then I feel like the personality aspect, it's not something we were really trained on, not something you're taught much. And that is where I feel like a lot of us really suffer, because you get out there and you think all you need is your intellect and your hand skills. And you start realizing, gosh, so much of this job is being able to mesh with patients, referring doctors, and there's all sorts of, cringy things that happen in the social personality realm that cause trouble for surgeons.
right, we can call them the core values of, if someone's asking, what should I do to open up my new practice? And we can talk about where some of those things, but it's like sit down and decide your core values. And the new social media influence in our profession favors one element of that triad a lot more, which is the excitement of the surgery and posting a coronal flap or a big surgical exposure on your social media and say, well, I'm doing these kind of surgeries. And that's always cool. I'm not a huge fan of seeing those kind of things. I think those should relatively kept private or on more academic venues than, for example, Instagram. But the surgical capabilities, or I'm doing something exciting that can be so exciting that can allow us not to focus on the other two pillars of the triad, which is one, people don't post much that, hey, listen, I read this book or I read this exciting article. We don't do that. So I think that's, and then on the personality side, you're right. Everyone has their own personality. You can't change that. It is who we grow up with, but you can perhaps adapt. And I did this to myself from the very beginning. I said, I really going to try to do whatever I can to be as nice as possible to my patients. It's essentially being a good doctor and think of them truly as your family members or people who are seeking your advice at a very close level. And if you can do that from the beginning and forget the surgical stance and you being a doctor now and just be more of a friend to the patients, that also those are good core grassroots, if you will, to build upon a practice.
For sure. I think there's a lot of like complex social situations we could get into that oftentimes we're not sure how to, prioritize and walk through those complex situations. Like, for example, let's say, we all have a situation where you have a patient who's comes in, they're rude to the staff, they're just very difficult patient. And, I see surgeons handle this differently. Do you take the side of the patient and cater everything to them? Do you protect your staff and tell the patient, hey, that's not okay to act that way in our practice? They're just kind of very awkward, difficult situations. And sometimes we're not sure how to navigate it when you've got, patients like that. Or, for example, if you have staff members, right, that aren't getting along, these are the traditional things that we just hate to deal with as a surgeon. We feel like I'm a surgeon. All I should be doing is cutting, not dealing with all of this, a bunch of crap that people have with their personalities that are clashing. How do you navigate stuff like that?
It's a great question. And, we get trained in surgery and whatnot. So that part, and as you go into practice, you keep doing a lot of surgery, you become better and better at it. But the hardest part of running a practice that everyone says is the staff and the management elements of it if you're in that position. But the one comment I would have, if you have a difficult patient, which we all will at some point or another, and they have some sort of criticism about either yourself or your staff or your setup or some outcome, I think the best approach is, even if you're really running a busy clinic and you're like, oh my God, I'm going to run behind now, you need to just suddenly stop and just sit down in front of that patient and sort of bring your own heart rate down and just relax and look at them. I say, say you were the patient. I say, Mr. Grant, I noticed that you're perhaps a little upset about something. Can you tell me, is there something particular that you can share with me to help me better explain what's going on? So I would put the ball in the patient's court, and I've done that on many occasions, and suddenly what they say may be very different than what you thought, first of all. Thought they're upset at something else, so you sort of say, is there anything that particularly has bothered you that I can help you? And that show of compassion usually brings sort of you back to the same level, and you have to not get sidetracked by whatever else you may be doing in clinic at that time and just focus on that patient 100% at that time. And I think that resolves a lot of times, at least shows the patient that you care and you notice that there's a sort of a tension going on. And then you find perhaps a means to resolve and say, well, if you're unhappy with one of my staff, let me see if somebody else can come and talk to you about this, or let me address this myself. Let's talk about this myself, and let me explain to you why this is the way it is. I had one patient a few days ago that was a very difficult situation of what seems a very simple concept. She has this complex pain in her body on her left side of her face for many days and many weeks, and I've seen about 8 different doctors, and it was about perhaps a tooth that was mistreated in some way, and the root canal material may have bothered her. So I decided to say, well, listen, it's a very simple. You may have all this complex neuropathic pain, but I think this tooth just needs to come out. This tooth needs to come out. So we took the tooth out, and she came back a few weeks later, and it's still hurting her. She says, I'm still having this neuropathic pain. And she was now mad at me a little bit for now having lost the tooth in addition. And I totally understood that, but I spent a good half an hour explaining to the patient why we did what we did. And at the end of that, and giving patients some science and say the reason is that we want to try to reduce the inflammation. Inflammation is the body's response that can cause pain. And sometimes intellectualizing it, patients appreciate it. So I think that's another venue to bring in our scientific reasoning side to explain to patients, this is why we do what we do. And at the end, she was very happy and very thankful that says, well, now I understand what's going on. Even though I'm not better, at least I know why we did what we did. So I don't know if
That's really helpful. Yeah. And I feel like sometimes maybe we think patients don't want to hear the science, it's too confusing. But I found not like that, even just small phrases about why we're doing this, why we give a shot this way, why we have to, I don't know, extract a tooth or prescribe a certain medication. Just one or two scientific reasons behind what you're doing. I feel like patients really appreciate that. They're always like, okay, I get it now. But I like what you're saying about sitting down with the patient, taking time, letting them know that you're there to listen and you want to understand what their take is.
In every one of my consult rooms, I have a whiteboard and a white erase board. And I really enjoy those. I've had those all these years, and I draw things for patients, and I may draw a fracture or a tooth or an implant or a nose or a nerve or whatnot. And I really, as I'm talking, I write notes on the board, and they love it. It becomes like a little lecture. It could be only 5 or 6 minutes. And then at the end, I take a picture of it with their name and date and put it in the chart. So it also documents that we had this discussion about this and that. So it becomes a fun thing and they sometimes get up and come on the board and say, well, what is this thing here? And I say, okay, so this is like that. And it really solidifies, you bond with the patient. It shows that you're teaching them something and they get involved too. And it helps document that you've had these discussions and you've had this interchange. So that's been fantastic. And I use an AI tool also that summarizes things on top of that. And it's been quite nice. I've enjoyed that whiteboard issue. It's sort of my little thing, and all the staff knows, and they see me start talking. Sometimes they walk out of the room because they know I'm going to be there for a little bit. They're like, here, do his little thing.
That's really cool. I like that. That's a great tip. So switching gears on the aspect, for maybe the younger resident surgeon who's saying, yeah, I'm still, despite all the DSOs and the practices being bought up, I, want to go ahead and try to, hang my shingle and buy a place and open my own practice. What recommendations? I know we talked a little bit about this, but what other recommendations would you have for that type of surgeon?
Right. No, it's a fundamental decision. And I tell this advice to my kids, it's that there's some decisions you make in life that you think they're big decisions, but they're not. Like which car shall I buy? You think that's a big decision, but it really isn't. It's the choices, or which clothes, or which party should I go to, or which city should I visit. These are not important choices because in the long term, they don't have impact. So there's 3 decisions I always say. There's 3 major decisions you make in your life outside of family, and which is, of course, goes first. Always. One is, what are you going to do with your life? And people who are listening to this podcast have already decided they're going to become oral and maxillofacial surgeons. So that's one thing. But the 3 of them interconnect. So that one, we just put it on the side. The other one is, where are you going to be when you do this thing that you like to do in your life, OMFS? So that's a huge decision, because where will take you, it's sort of a decision that you make, and if you suddenly change it, it has a lot of repercussions for you to move somewhere else. The other one is, who are you going to do it with? Meaning not just your personal partner in life, your spouse or your family members, because that is intricately related to this. So where are you going to be, and who are you going to have a relationship with, and what you're going to do? All those things are not independent. They're all very connected. Family is connected to your profession, and where you are is connected to profession. And so when you say which DSO or which private practice or academic shall I join, you can't make those decisions without thinking about the other 2, first of all. So you can say, well, I've decided to go into work in a DSO. I've discussed it with my family members, and we want to do it in this city, and I want to practice this scope. So you have to plan those out. It's not just about, yeah, I'm going to do private practice or I'm going to do academics or DSO or whatnot. All these other things have to go into it. So if that makes sense, it's a very complex decision, because if you do any one of those wrong, so you choose the wrong profession, the wrong spouse, or the wrong city, putting a reverse gear on any of those is going to change all the other two in some form or shape. At least it impacts them severely. That's more than you wanted to hear, perhaps, but to answer your specific question is that, well, the folks who are graduating, they have to sit down with themselves with maybe that background and say, what is it that I want to do with this training now, and what venue and what are my financial needs or my family obligations? Because there's truly a huge dichotomy or even a trichotomy in our profession now, as far as DSO being one branch, private practice where you're the owner being one branch, and academic oral maxillofacial surgery being one branch. Those are three branches that you could take, and you have to decide that at some point, and you can change here and there a little bit. Some of them are harder to uproot and change. So, for example, if you're in a DSO, you can quit anytime, as long as your covenants allow, and move to another DSO or to another city. If you open up a practice, say in Atlanta, Georgia, or in Denver, you can't just after 3 years and say, I'm leaving, because you've spent a lot of time.
Yeah.
Mobility is less. Where on the academic side, you can always switch universities. Generally, you can say, well, I'm going to move to a different state or a different institution. So those are important questions that the colleagues or the young folks have to ponder upon, that I didn't think about. I just went with my gut. This sounds good. I'm going to go here. This is a good decision. I'm going to do private practice. I'm going to do academics. I'm going to do Atlanta. What it is, where I'm going to, pursue this venue with not much future thought. And so if the one advice I could give is that make the decision of the present moment with view of the future implications, not just this sounds good, or it is be mindful of the future, and be in the present at the same time, if that makes sense.
Yeah, that definitely does. My experience, with residents reaching out to me and asking questions, it seems like, so like you're saying, most know, that they're already decided they're doing oral surgery. It seems like most already know where they want to be. That's not entirely true, but the majority kind of say, oh, I need to end up here, where I want to live for the rest of my life. And then that's the main one that everyone struggles with is, okay, it's much harder now, I think, in most people's minds, just to open up your own private practice, because so many DSOs control the patient flow and, where the referrals are coming from. And so there's a lot more hesitancy, a lot more fear about, committing to, I don't know, real estate, to practices, to opening up and getting a huge amount of debt behind you when maybe you will have trouble getting patients. If you're not part of a DSO and you don't have all this, powerful connections to the referring doctors. I mean, any thoughts on that? Do you feel like if you just market well, are you going to do fine as a private surgeon? Does it depend on, where you're at in the country, or what are your thoughts?
Right. No, I think most people are going to do fine no matter what. It's between how much more or less you're going to make and how much stress you're going to put on your shoulders. The seduction of a DSO, so to speak, is that you don't have to worry about much. Just show up to work and you will make money right away. And so it's that old adage, if you want to build something, you can't just have it the next day. If you want to build your own practice, it can be done. It can be successful. You have to be a good doctor and present well. You don't have to market necessarily like crazy, but if you provide good service, usually within a few years, it's reflected. The DSOs cover a different set of patients. It's purely and exclusively dental alveolar surgery. It does also eliminate folks' surgical training. After 5 years, you sort of become institutionalized and you forget how to do surgery. You just, know that, and you go into that direction, which is what it is. So I think that it's very geographically dependent. I think any oral and maxillofacial surgeon can open up a practice just about anywhere in the country, as long as it's not super saturated area, and probably do okay. But there's another pathway that you can use that mixes those three branches that I said, is that, say you want to open up your practice new in Denver, where you are, and you open up a practice, clearly that day you are not going to be busy the first day you open up. And so the few things that you need to do is, one is probably have some part-time DSO work to do while you're making your practice so that you're not as stressed out. So you do some outside work while you're building your practice, because building a practice takes 2, 3, 4 years, or even maybe 5 to get it to a certain level. And you can say, I'm no longer going to work in the outside, I'm just going to work in my practice. And that's one. And second, you have to, like you said, you do have to take a little bit of financial debt to start those practices. It's just the way it is. You're not going to just free, like you will have to take a few $100,000 in loans, and you're going to have to hire a very good office manager, which will be your best friend, because they need to be there, and they need to get paid from the beginning while you're not getting paid, at least from your practice side. So the ingredients is patience. Mix it up, start your practice and work outside, and find a good office manager that can be your ally, and reward them well, because they're going to be your key to success of your private practice. And then define yourself in your private practice. There's a couple other voids that are happening in the profession is, and I think something different may happen in the next decade or so, is that the burden of lack of coverage for major maxillofacial surgery is now becoming more notable in time, and because of the difference in the economics of it. So there's a far more dental-alveolar surgery, but I think we may see a shift to where some of the maxillofacial surgery may start paying a little bit better. I think that may happen in trauma and reconstructive surgery. Cosmetics is a different venue, and so I emphasize again, since our last talk a year ago, that whatever venue you go, whether it's the private practice or your DSO or a mixed blend, maintain your surgical skills. And I want to take a message home on this concept, is that it's not about, so maintain your surgical skills, because that's what's going to allow you to later on suddenly navigate in and out of one of those venues, to go from one thing to another and still be able to do it. And I'll say this, is that it's not about which procedures you learn. So in residency, you will learn how to do a particular operation, a sagittal split, or maybe you learn how to do submandibular gland removal, and so on and so forth. You learn these procedures, and that's great. But if you can maintain as a surgeon, be a competent surgeon, not procedural, but just how to operate. That's what matters, because if you know how to operate, you can adapt to new procedures, or any procedure. Maybe with some read into it and some observation, you're able to sort of go back and forth because you are a good surgeon. It's like being a good driver. You may be a good driver, and you drive in Denver, Colorado, because you know the roads there, and you've been doing that every day. But if I suddenly put you in Rome, Italy, you don't know the roads, but you're still a good driver, and you can still drive well. It's a little bit, you have to focus a little bit more and make sure you don't miss stop signs and whatnot. But you learn to become a good surgeon or a good driver, so that you can drive in any city or drive in any surgical arena that's part of our profession, the head and neck, so to speak. But that allows you to go back and forth if you decide to shift gears. And if you go into a DSO setup, which sometimes you just have to, because you've been in debt, whatnot, find a way that perhaps you can maintain your surgical skill set. And we've emphasized that in the past.
Yeah, that's a really good point. I mean, what tips do you have on becoming a good surgeon, so to speak, or a good driver? I mean, how do you develop those skills? Is this in training? Like what in your mind makes a good surgeon?
It's good. It's really several things, and and so these are my opinions on this. But one is that having good surgical skill set, soft tissue handling, knowing the anatomy really well. When you're driving a car somewhere, Grant, and you're before GPS days, of course, if you remember anything like that, and then you suddenly say, wait a minute, I don't know where I am anymore. It's like I'm sort of lost a little bit. And you look around and you're like, well, I don't know which part of town I am. I got to be at this place in half an hour. And you sort of get this little cold feeling in you. Shoot, I don't really know where I am. It's that same thing in surgery when we've all maybe been in this situation where you're doing in the middle of an operation, and suddenly you're like, wait a minute, I don't know what to quite to do next, or it's a little bit, what shall I do right now? Or anatomically, say you were looking for a certain structure and you can't find it. You're like, hold on a second. And you look around you and you realize you have like two assistants that have no knowledge of anatomy. And you're standing there, an anesthesiologist there, putting the patient to sleep. And in your head, you're like, holy, wait a minute, what am I going to do right now? How am I going to stop this bleed? Or I don't really know what's going on. You get this cold feeling that goes down your body. You want to try to prevent that. And the way you prevent that is by knowing anatomy really well, so that you're not suddenly second guessing your anatomy in the middle of the surgery. You're like, well, where is this nerve? Is this? And you have foundations to go back on. That's number one. The second way you prevent that cold sensation is planning as well as possible ahead of time. So you have a plan. You've thought about this surgery ahead of time. So you have a plan. I still to this date on the more complex surgeries, I find a moment that I go and stand before surgery or that night or that morning, and I just go through it in my head. I'm going to do this, that, this, that. The other is saying, I'm going to drive to the airport. I'm going to go down this road, take a right here, go down there, and then go this way. And eventually I get to the airport and that kind of thing. So some preparation, some confidence in your abilities, knowledge of anatomy. And I've been in those situations, and I bet everyone has, that they're like, wait a minute, what am I doing right now? Or what shall I do at this moment? And then sometimes the answer is you just have to stop there for a second and don't second guess. Just stop for a second and say, well, let me just pack this wound. Let me think here for a second. Because we're good thinkers, but remember, you can think always better if you have a little bit of time. It's like taking an SAT test. You can probably answer most questions if they gave you enough time. Half the challenge is that you got to make these decisions immediately. In an SAT, you got a minute to answer a question, but if you had 20 minutes to answer that math question, you probably would get it right. I always think that way. I say, well, let me just stop you for a second, or even just if the wound is stable, if it's not an active bleed or something, and just go back to the thing and say, well, let me think about this for a second, and let me dry this wound and just suction and irrigate for a little bit as I'm thinking around. And then you come back and say, oh yeah, okay, wait a minute, this makes sense. This is the hypoglossal nerve here, and this is the lingual nerve, and this is what it is, and you sort of orient yourself. So that's what's I've done.
That's a great point.
Tangent a lot on you, but yeah.
Yeah, that one I feel like has taken me a few years to get to, because maybe I'm